so in 2021, I gave a talk on basically kind of where probably the field of deep brain stimulation was going to go, and targeting, programming, new indications, that sort of thing. And so this is a follow-up to that presentation, which essentially from that time to now, what really seems to have risen to the top, unsurprisingly, for innovations in deep brain stimulation, particularly on the programming side, is a finding called local field potential. And so we'll talk about what that is, and I have no disclosures, as well as the current clinical applications for it. So what can we do with local field potentials now in the clinic? What are new innovations? So recently, the company that uses local field potential clinically for deep brain stimulation program called Medtronic also received FDA approval last week for something called adaptive DBS, which takes local field potentials to the next step of the ultimate dream of closed loop deep brain stimulation. So we'll talk about where that's headed, where we might use that, and then expansion of our understanding about how local field potentials can deliver stimulation in other movement disorders as well. And non-movement disorders, actually, we're going to talk about OCD, which also has a well-accepted application as well for deep brain stimulation. So what is a local field potential? So a local field potential is basically aggregate electrical activity from local neuromembrane currents around an electrode. So it's picking up on the currents around an electrode. And it's a summation of the currents around the electrode. And the signal can differ from electrodes separated only by about 1 millimeter. So it's very local when we talk about local field potential. These LFPs are identified by frequency bands, just like frequency bands that we see on EEG and other brain recordings. And basically, what we usually get clinically in the reporting of a local field potential is either just raw data, so you can see the LFP, and I'll show you what that looks like, or we get it reported in a unit called power, which is what we see in the clinic typically is a power statement about what the local field potential is for that particular patient. And power is basically the summation of how many neurons, the geometry of those neurons, that neural signal, and the strength of the synaptic input. So synergy, essentially. So it's the level of synchronization within the local neuronal population. So the most accepted use of local field potentials clinically is in Parkinson's disease. And people with Parkinson's disease have a usually easy to detect local field potential called beta band. So it's the beta frequency, and in the targets that we use for deep brain stimulation, the subthalamic nucleus and globus pallidus interna, the beta band is present in many of those people. An abnormal beta band, I should say. We all have beta, we all have gamma and theta and all those things. But in people with Parkinson's disease, the power of beta is abnormally elevated. So beta oscillations in people with Parkinson's disease directly correlate with the severity of their motor symptoms. So more power beta, the higher power beta, the more bradykinetic they are, the more rigid they are. So this, in normal people, beta usually occurs in very short bursts. So we can see sort of low synchrony of the data in usually pretty normal people. But in Parkinson's disease, the duration of those bursts lengthen, and that increases the power, essentially. So in people with Parkinson's disease, we see a high synchrony in the beta signal in subthalamic nucleus and GPI, which gives us high beta LFPs. And so below here, so in B at the bottom, that's usually what looks like on our side when we're doing deep brain stimulation. We see a high beta peak. So on the bottom is frequency, and then this is beta power on the y-axis. And so the red high synchrony equals high beta power. So that's what we're interested in, detecting, figuring out where that's coming from, and trying to suppress it, essentially. Because we know that if we suppress it, then if it's high and the patient's bradykinetic and rigid, if we bring it down, the low power must equal low rigidity, low bradykinesia. Does that make sense? Okay. So the only issue that has come up, really, well, one of the issues that clinically is important is that voluntary movement and some degree involuntary movement can suppress beta oscillations. So a very tremulous patient may also not have very high beta signal. That has come later in larger studies to show probably not that significant. So even very tremulous patients can have high beta power, but sometimes depending on how we're trying to look at it, that can make it a little more complex to detect changes in the beta based on what we're doing. So that'll come up in a minute. So what you were seeing here in the graph is something that I showed in my previous presentation, which is basically these LFP, this is raw LFP data, and that's at a beta frequency. And then the individual here is off their levodopa. So they are rigid and bradykinetic, presumably. And then when they take their levodopa, that oscillation significantly changes. And so at the bottom is a power graph again. So you can see a beta peak when the patient's off levodopa, and that beta peak disappears when they go on levodopa. One interesting part about this graph is that the patient does develop a gamma peak, which sometimes is associated with dyskinesia. And so that may be something that's relevant also in terms of being able to fine tune and determine when we're overstimulating or understimulating individuals. So where did this sort of settle out? So for a long time, for the last several years, we've been able to get this LFP information on some of our patients who have the Medtronic device. In Parkinson's disease in particular, we're interested in patients who have a subthalamic nucleus or a globus pallidus interna target. We can get this data on anybody, regardless of why they got deep brain stimulation, but sometimes we don't have usable data that we can evaluate. So still really focusing on Parkinson's disease and those Parkinson's targets. And that was the basis of this clinical trial. So Medtronic, who has this technology, sponsored a clinical trial called ADAPT PD. And they use this data to get FDA approval for something that they call adaptive DBS. And that happened last week. So starting in April, we'll be able to use this technology for what's as close as we can get to something called closed loop stimulation, which is basically that it's reacting to the patient's brain activity rather than something that we preset, which is called continuous DBS. So continuous DBS versus adaptive DBS. So there was pre-existing sensing deep brain stimulation hardware, and then this is a software change. And their primary endpoints for this study were really to see if adaptive DBS mode was able to improve or at least not worsen daily on time without troublesome dyskinesia, exceeding a patient-specific threshold defined as continuous DBS baseline daily average on time without troublesome dyskinesia minus 2 hours. Basically, that's a non-inferiority statement. They actually ended up changing their primary outcome measure post hoc, which I think is important to recognize. So they want to show that adaptive DBS versus continuous DBS is really no worse in terms of giving that person the on time. The other primary endpoint was based on energy. So these patients have a battery in their chest, just like a pacemaker, and most of those batteries are primary cell, which means that they have to be replaced when the battery runs down. And so what is the energy demand of using this technology, and how might that affect how often the patient has to have surgery? So the study design was basically all enrolled patients got set up with continuous DBS first, standard care, and then over a 6-month period, the patients got randomized into either single threshold DBS mode, adaptive DBS mode, or dual threshold adaptive DBS mode, and then they switched. So the shortest period of time that the patient was followed, if they continued to the end of the study, was 6 months. The longest period of time was an additional 12, so a total of 18 months. And that was open label at the end. So when looking at adaptive DBS and what's possible, there's two modes that we can choose. So we measure the beta band power and then figure out where we can suppress that. So what type of stimulation helps to suppress that, and then set that patient at that number. Here with single threshold, we pick a number basically to say this is where the patient responds the best. And then the deep brain stimulation software does its best job to try to stay as close to that line as it possibly can. So a single threshold. And so you can imagine over time, it's doing a lot of ramping up and down. The other option is dual threshold, which basically sets a high and a low. So all you have to do is stay between the bumpers instead of trying to stay close to a single line. And so there's more variation in terms of what the stimulation might be doing, but it's a lot less ramping up and down. So trying to compare these two. And so for ADAPT PD, the results were that 85% of screened subjects had usable LFP data. I think that's important to start with because this was 10 centers. Centers, of course, that they chose because they do a lot of DBS and they're very experienced, but the vast majority of patients did have usable LFP data. So if you chose to take the chance and say, I want to put in a Medtronic DBS so that I can use this technology for my patient, the likelihood's very good that when you get the patient in clinic, you're going to have some usable data. In a Parkinson's disease patient, that's all Parkinson's disease patients, either an STN or the GPI. The primary endpoint was revised post hoc. Basically, what happened is that they didn't get statistically significant differences in the off time without dyskinesia or on time without dyskinesia. And they did revise basically that one standard deviation difference from continuous DBS to adaptive DBS in review. 79% of the patients met the primary success threshold for single threshold DBS. So the one where you've got the one line that you're trying to stay close to. 91% of patients in dual threshold DBS met the primary endpoint. So it does seem like dual threshold DBS probably does outperform in that way a little bit, but the difference actually wasn't statistically significant. And so their take home essentially of the primary endpoint was that most had no worse than 2 hours per day less good on time using adaptive DBS compared to continuous DBS, which is a very vague statement, of course, but essentially it's not inferior. The dual threshold mode was statistically significant in improving on time without troublesome dyskinesia by 1.3 hours per day and a reduction in off time by 1.6 hours per day. So that was statistically significant in terms of improving their on time without dyskinesia. When you think about deep brain stimulation already, so one thing that's hard to sort of put your head around, especially if you're not familiar with the original data, is when you compare deep brain stimulation to best medical therapy, DBS already is significantly better about improving on time without dyskinesia and reducing off time by several hours. So depending on what piece of data you look at and how big the sample size is, you can really see an improvement of 2.5 to 4 to even sometimes 6 hours per day improvement in off time compared to best medical therapy. So if you take regular continuous DBS already giving you that much, and then trying to go on top of that an additional 1.5 hours or something like that, that's basically what in reality we're really looking at. That's drawing a conclusion that we probably will never have direct comparison to best medical therapy because everybody agrees that DBS is already better than best medical therapy for the right patients. But that's really in reality, even though that doesn't seem like very much, we know DBS is already quite good for people compared to best medical therapy in the right circumstance. So 98% of patients with adaptive DBS, once they were in the open label period, did choose to stay on adaptive DBS during their long-term follow-up. So almost all patients wanted to be on adaptive compared to continuous DBS once they had the choice. But the TEED results were not clinically significant in either mode of adaptive DBS. And TEED, again, is basically that energy use. So it's interesting because they were hoping that by the DBS being able to turn itself down at times with the patient, that would save battery. And it didn't. Mainly probably because it also is using a lot of extra battery to do all this sensing and adjusting. So it's important, and they did make a statement in their FDA application that this is a conversation that we probably need to have with our patients, especially patients with primary cell batteries, that using adaptive DBS could mean that they would have to have surgery more often. So the other thing that got approved in February is something called electrode identifier. And basically it's just a fancy software that helps us to choose what settings would be best for the patient based on their brain sensing data. Currently, the way that we do brain sensing is we bring the patient in off medications and we run a survey and we get a chart like this at the bottom. And this chart looks really similar to what I showed you at the beginning, which is this big beta peak. And what you probably can't see very well in the background is lots of other little kind of grayed outlines. And what the data that spits out is peaks at every location along that electrode and trying to select where the signal is the strongest in that area. So where do we find the best signal, and where, in theory, stimulating there would suppress that beta peak and give the patient better outcomes. So at this point, this is what we do. We get information about where we think the best place to stimulate would be. Then we go into the programming session, do that, and then we have the option to live stream the beta peak while we're adjusting stimulation to figure out if we're being effective or not. That also can give us data about that single threshold or dual threshold, kind of where to set the highs and lows. But we have to do all that manually now. And what got approved for software in February was basically a computer program that does this for us. Now, this is interesting because there was a couple of studies. The one that Medtronic primarily used for their application was this Thompson study, where they demonstrated an 85% improvement in clinic efficiency for initial DBS programming. This hurts a little bit because people who do DBS always feel like that blood, sweat, and tears that you spend trying to figure out where the best place to stimulate is worth it. But now we have a computer program that can do it in 20 minutes. And so that's okay. But what's interesting about this is that this opens up a door, an opportunity for maybe more people with DBS to get cared for in the community if this really works. So in the right circumstance, this could be a useful tool for patients to get more treatment, but also improve our efficiency too, so that we can see more patients too. They also showed non-inferiority, essentially a comparable efficacy compared to traditional programming methods. So if they did a monopolar review, which is where you go through each and every place on the wire, test it, figure out what works, figure out what doesn't, and then do the electrode identifier, the results were comparable. So that's Parkinson's disease, and that's kind of where we're at with Parkinson's disease, which is a big change compared to where we were talking about it in 2021, where we were just starting to learn about what LFPs were and how we might use them. So that was commercially available technology in 2021, but over that time frame, it's evolved to basically become something like adaptive DBS. But we've only talked about beta. And so are there other LFP frequencies of interest? And the short answer is yes, but some of it we don't really know what to do with. And one of the really big challenges is particularly tremor, essential tremor being the primary reason that a lot of us do deep brain stimulation, and having a difficult time finding usable LFP data to treat patients with essential tremor. There's also frequency bands that are associated with dyskinesia, like we were talking about. So helping us to understand if we're overstimulating a patient, tics, dystonia. Dystonia has been also a little bit disappointing, trying to really hone in on dystonia bands and the response to those bands to stimulation. And I'll talk about that very briefly. But several things that we potentially could use to expand the ability to treat these patients with more certainty. One thing I wanted to talk about was obsessive compulsive disorder. There's very little data about LFPs, but the data is promising. And the reason I think this is important is because this is something that's very subjective, that we do deep brain stimulation for, but try to figure out if we're being efficacious can be hard. And also, a lot of the people that are meeting these patients for the first time and saying they might be good candidates are not movement disorder neurologists and are not people that are used to doing deep brain stimulation. So how do we help to expand and do a better job for these people? And this is potentially an opening for that. So this was a study that looked at 5 subjects. They had bilateral electrodes placed in either the ventral capsule / ventral striatum or the bed nucleus of the stria terminalis. And if you're like me, visuals help. And so the ventral striatum here is in yellow. And you can see the electrode, the dotted lines coming in from the sides. And that's roughly about where they placed most of these electrodes. And they used the brain sensing technology for these individuals. And all of the individuals in this study did have delta band power that showed a negative correlation with their OCD symptom intensity. So not related to their stimulation, but just open recording and observation from the clinician, home diaries, a variety of different ways of assessing it. And there was a strong inverse relationship between OCD symptom intensity and delta band power. Super small group of people, similar data from other studies, but giving at least a clue about how do we know if we're being successful? Are there ways to measure for the individual if we're being successful aside from observation, patient reporting, those sorts of things? And this is potentially a helpful tool for figuring out where to stimulate in the future as well. So they haven't been able to show yet at this point if stimulation helps to improve that relationship between symptom intensity and delta band power. But it's a helpful tool, I think, especially for conditions like this where it's very hard to objectively measure their symptom control. Tic disorders is something that anybody who's taking care of a deep brain stimulation patient with tics can be very rewarding, but also quite challenging. And so the field is very split in multiple ways in terms of choosing the best target. We don't even know what the best target for tic disorders is at this point, but also trying to get objective measures of improvement. Now, a very severe patient that's going to go through deep brain stimulation is probably having tics all the time. So you can usually tell if you're being successful. But in terms of target selection for the future, this might help us to weed out what the potential pros and cons of different targets might be. And so 2 studies that I wanted to feature that, again, were also small groups of people, but hopefully will pave the way for more information in the future, is the first one, a local field potential of the thalamus. So that's one target that we use for tics in Tourette syndrome. And in these individuals, they did show a correlation with tic frequency and a decrease in the thalamic background activity in the alpha frequency band. So if the increase in tics resulted in a decrease in the alpha frequency band. So another biomarker potentially for severity of tics. And then the globus pallidus interna target is also a well-accepted target for Tourette's, and they also found a different frequency band, so alpha and beta, statistically significant oscillatory activity in these individuals. So big power alpha and beta frequencies in the GPI for individuals with tics. So potential targets, again, for individuals for stimulation, figuring out the best way to stimulate, where to stimulate, how to measure objective benefit. Because one thing that I didn't talk about really in Parkinson's disease that we can do is do home recording as well. So we can leave the sensing data on the sensing on and collect data over long periods of time if we set those limits and say, I want to know what's kind of in this frequency or within these limits. And it can give you data over time to see if you're improving. So you can see a trend, which could be useful, again, in things that are a little bit subjective or sometimes hard for that person to be a good historian, or allows us to be able to tell if we're on the right track, which is sometimes a challenge for people who were programming for tic disorders. Essential tremor. So I'm very interested in this as a future application. And the literature recently has actually shifted in a way that I think is very interesting. And so it makes total sense, but it wasn't something that I thought of, which is why these people are scientists. But the recent literature looks at something that basically will mark activity that is tremor provoking. So it's not really measuring tremor, but being able to identify activity that would likely lead to tremor and then stimulate reactively to that movement that would likely lead to tremor. So being able to adapt, again, so be at a low level of stimulation when the patient's resting, recognize brain activity that's associated with tremor behavior, tremor provoking behavior, and then stimulate before the patient develops tremor. So knowing that we would have to set up basically the right settings for the patient that does suppress their tremor effectively, but then allowing the stimulation to be turned down when they're not doing that activity. So it's not detecting tremor, but it's using that information that we know about voluntary movement, for instance, suppressing beta activity, and then reacting to things like that that would likely be tremor provoking. So both of these are looking again at using closed loop therapy, which is a little bit further beyond where we just talked about with tics and OCD, because those are a little bit still early phase of not knowing what stimulation would do for those individuals. But tremor inducing movements so both of these are in the ventral intermediate thalamus, intermediate nucleus of the thalamus. At the first study looking at a reduction in beta and an increase in theta. So very early, they demonstrated that if they saw this shift occur and they stimulated right at the time that they saw that shift, the patient was able to achieve tremor suppression before it ever even really occurred. Because that was marking a movement that would likely be tremor provoking. And then the patient was able to have low amounts of stimulation when they weren't active. Now, why is this important? Well, twofold. It helps to save patients with their battery so they don't have to have surgery as often. But also, we know that most people with particularly essential tremor and thalamic stimulation benefit from having intermittent breaks from their stimulation. It's good for them to not have stimulation on all the time because sometimes their tremor attenuates to the stimulation. So giving them intermittent breaks is good. And it probably does allow them to have better longitudinal control compared to continuous all the time stimulation. And we know that people with essential tremor don't need stimulation all the time. They often turn their stimulators off at night. They do just fine. Turn the stimulator on in the morning, and that works great for them. So this is the idea of being able to do that in real time. The second study, which is more recent, looks at really just high beta amplitude being a trigger, a change in high beta amplitude being something that can trigger the stimulator to turn on so that they can react to the movement that would likely cause tremor. So I think this is an interesting idea that I didn't really imagine would be the likely target for essential tremor, thinking along the lines of the way we think about Parkinson's disease, because this is not a marker of disease severity. This is not a marker of the disease at all. This is just a marker of movement. And knowing that every time that patient tries to use their hands, they're going to have tremor. And so reacting to that. Okay, final thing. We're going to come back to Parkinson's disease. And this is my favorite study about Parkinson's disease. So this was a group of patients that were at two centers that had their recording LFP data on all the time. So they went on with their LFP measures. And this group got together and figured out that all the patients that they reported here had a statistically significant reduction in their beta band activity at Christmas. And so basically, all the people in the study reported they spent Christmas Eve and Christmas Day with family and friends, and they had totally unprovoked. They didn't take any extra medicine. They didn't do anything different. Their beta went down because it was Christmas. And I'm not saying it has to be Christmas, but we did see, and this would theoretically correlate with them having reduced symptoms of their Parkinson's disease during this time frame. So if you can't see, there's a little reindeer sitting on their STN over here, and was very cute, I thought, that hanging out with family and friends is therapeutic. So in conclusion, local field potentials have shown staying power and maintained clinical relevance in the advancement of deep brain stimulation program. And so I think this is going to be here to stay. We'll see how significant it is in terms of the impact on patients. And to be honest, the things that have been advancing in Parkinson's disease in particular haven't shown a huge improvement on the patient side of things. It has the potential to be an improvement in the patient side of things. But in Parkinson's disease, essentially, it's just showing us that we're moving in the right direction, but with its current clinically available iteration, we don't have significant improvements in the patient experience on time, without dyskinesia, reduction in off time. Those things are pretty similar at this point to the traditional way of doing things. So we're not missing out if we're not implanting this particular type of device, but we know that we're probably moving in the right direction. In these other conditions, particularly things like essential tremor, other things that are a little bit more subjective, I think that's going to be very useful if we're able to get to the point where we can use this as disease biomarkers and indicators of response to therapy. The characterization of the LFPs in Parkinson's disease has led to the development of new technology, which I think is an important stepping stone. But like I said, in Parkinson's disease, it's probably not going to be that huge of a difference compared to, at least in its current iteration, compared to how we traditionally provide care. It's going to make a big difference probably on the provider side of things. And I think that can help patients, just because it'll make all of us a little bit more available, hopefully. So I think that'll be an important feature to look out for. And the expansion to non-movement disorder clinicians that might be interested in deep brain stimulation, if they have more solid indicators of success and suggestions from the device on where would be good to stimulate and how to stimulate the patient effectively, would help to probably expand the indications and the care that those people are getting. And that spending time with family and friends is therapeutic. So, all right, any questions? Yeah.
Okay, with slide 12, you're talking about DBS for OCD.
Yeah.
Does that have any generalized ability to hunting behavior in Parkinson's relation to be thought of as like a totally different phenomenon of organization?
We have no idea. One of the reasons I will say is, so there's not been any publication. So this is a question about OCD, sort of only OCD treatment for with deep brain stimulation versus OCD type behavior in Parkinson's disease, and would stimulation be applicable? So I haven't seen any data about trying to suppress behaviors in Parkinson's disease that we would characterize as something similar. One of the things that's limiting, like if we want to try to observe that in the clinic, and I'll go back and show you why, is that you look at this chart at the bottom, this is really what we see in the clinic when we're looking at patients. And so in the delta frequency, it's no man's land, it's black. And so very hard to interpret anything that just naturally occurs in those lower frequencies with the clinically currently available device, because you'll see typically, especially on figure 1B over there, a very large spike in that delta frequency that is artifact. And that's, usually kind of a combination of things like stimulation artifacts, EKG artifact, different things that occur in that frequency band that the device can't tell what's significant, and we can't tell either. So we try, and we have tried, particularly for not OCD, but for dystonia, because dystonia does tend to have a correlation with lower frequencies, like in the delta range. But because this device is not yet able really to filter out a lot of artifact at those frequencies, it's hard for us to be able to use it clinically like that. So there's software that is available that can differentiate all of these things, which is where this data comes from. That's not clinically available software that these people are doing the research on. But in the clinic, it would be hard for us to say, oh, that would be hard for us. And so there's no publications on that at this point. Yeah.
Great. So I have two questions. Do we have any signature for the freezing of gate? I mean, do you have any idea what's happening?
Yes. Not pure LFP power signals. So in the data that I've reviewed previously for that, things that I've read, it's things that are a little bit above and beyond what this can do at this point, which is really looking at synchrony between multiple areas or like multiple bands. So comparing the synchrony between a gamma and a beta band or something like that. And that synchrony being something that's an indication of the freezing. And so something that this is not yet able necessarily to do. So there probably will be, but I think it'll take much more sophisticated technology. And truthfully, that'll be something that I think after we get past the electrode identifier and that working very well, and basically AI being able to analyze the bands and tell us what to do, then I think we'll be able to get to the point where we can look at the interplay between multiple LFPs.
And the second part, my second question is different.
Yeah.
So it's obviously very different strategy when you program SDN and GPI.
Yeah.
So is there any kind of post-hoc data looking whether, I would assume that this is kind of more helpful for GPI, but with any sort of data to support this assumption that, because that would be my sort of gut feeling that it's much better for GPI.
Right.
But it's supported by data.
Not really. And most of the studies really just, I think, in order to get an N that's statistically significant. For Parkinson's disease, we're really looking at trying to get big numbers, and all of those are mixed. The synchrony data on freezing a gate, I believe, was mostly in the GPI, actually. And again, those are a couple of patients here and there at this point. But those were mostly GPI. I can dig those back up for you and send it to you. But at this point, all of the data, ADAPT PD was about, I think it was 150 patients. That was all mixed, STN and GPI. And pretty much everything prior to that and since that then have been mixed. They did have, I found a paper that I thought you'd be interested in that was patients that had both STN and GPI implant in the same patient, and using BrainSense to basically help parse out what each target's doing and being able to the interchange between what GPI can control for that individual and what STN can control for that individual. So very early potential for that, but it's an interesting thought of figuring out the balance between those things. So yeah. Yeah.
Some of the side effects of the lowering the beta oscillations, not memory or mood, sleep,
right?
Those.
So the questions about potential side effects of turning down stimulation in response to where the patient lives with beta power, and so that isn't mentioned, and probably the reason behind that is just because the amount of change is pretty small. When we set up those, particularly the dual kind of bumper system where you can't go too high and can't go too low, the amount of ramping up and down that it does is actually within a pretty tight range. So the patients can feel usually some side effects of stimulation, like as it's starting to ramp up, they may feel like some tingling or like a rush feeling or something like that. Ramping down, they didn't really report much in terms of the patient noticing non-motor type symptoms. Again, the slightly biased probably report from the ADAPT PD trial, but the vast majority of patients actually did prefer adaptive in the long term. So thankfully it seems like it's not much of a difference. So yeah, it mostly was the ramping up that I think most patients complained about. Yeah.
So a simple question about TPS.
Yeah.
So at like they need to switch between next therapy, they have to do sort of to have that same effect.
You mean like if you were comparing to continuous DBS to adaptive, like switching to adaptive from traditional DBS? Oh, well, so at this point, the longest term data that we have for adaptive DBS is 18 months. Yes, absolutely. Yeah. A lot of our patients, once you get them, so that's kind of just a general concept. I think I'm answering your question. Just tell me if I'm not. That for deep brain stimulation for people with PD, controlling motor symptoms in Parkinson's disease with DBS often isn't that big of a moving target over time. Many patients will get put on a setting and be able to remain on pretty close to that setting for years. And so even though you think about it's a degenerative disease and that you're trying to constantly catch up with them, their motor control usually remains pretty stable for longer periods than what you would expect. And so adaptive, theoretically, for those individuals would be something that you wouldn't have to adjust very much. But in terms of like long-term beta trends or beta power trends in an individual, we do not have that data. And like if the beta would become more prominent in a new area or a different area over time, or that kind of thing, we don't know.
And many of those symptoms are likely to responsive to deeply developed problem.
Right. Yeah. Yeah. So some of the symptoms we're trying to control not being levodopa responsive. So that's also an element that we see often. If we can get control of dyskinesia, for instance, with DBS, that improvement is very long lasting. So you pretty much always maintain that level of control. If you're able to get it in the first place, you're able to maintain it for the long term without much change. Well, good. Thank you, everybody. Oh, wait, there's a chat. Hang on. So somebody asked, do we see any evidence that these dual adaptive therapies might affect mood or cognition? So yeah, that's similar to Hannah's question. So I hope we answered that. And then Dr. Brown just said, thank you for repeating the questions. Thanks, guys. Have a good day.